Today we're very fortunate to have Dr. Larry Burgess, an ear, nose, and throat specialist who knows a lot about the common problem of vertigo. He did change some of his presentation, but don't worry because I can send you anything that you don't have in your handout. Larry has also been a convincing advocate for JABSOM's internal giving campaign. It's important people realize that those of us that work at JABSOM also support the school. And that's really important, and Larry has led the way. So he's really done a great job. So please welcome Larry.
All right, good morning, everyone. I'm a professor at the School of Medicine, as she said. I'm also a practicing otolaryngologist, otherwise known as ear, nose, and throat surgeon in the community. So we see a lot of dizzy patients. It's very common in the elderly. All of us in our lifetime will experience vertigo or dizziness to some degree. The key portion here is usually it's a benign type thing. Yes, it can be quite severe, but the big thing is it can lead to falls and then head trauma or broken hips. And that's really the bad part about getting dizzy, because if you get one of these, it can be quite debilitating. Some of you may already have had a broken hip or something like that where you're hospitalized, or family members. The rehabilitation process can be quite long. We all know of people who might have had an accident in the shower, fell and hit their head because they were dizzy. That can be quite debilitating as well, and it can even lead to death. So we have to really watch ourselves and try to prevent some of these things. So let's go over some of the terminology. I think this is important. If you use the term vertigo, that's really talking about the room spinning. And this is primarily an ear problem. It's not a brain problem or an eye problem. If the room is spinning, it's an ear problem. Whereas generalized dizziness, it could be related to a lot of different things. And generalized dizziness, we're talking about a sense of imbalance. The room's not spinning, but you feel lightheaded. You feel woozy, a little unsteady. And you need all of these things there to help you from becoming unsteady. So your eyes have to be together. Proprioception, what's that? How well do your feet and your knees and your hips sense the ground and keep you stable? All right? Hormones, metabolic, also your blood pressure, anything out of whack there could lead to a sense of imbalance. Your ear, of course, and then your brain, how it functions, how it relates to the rest of your senses is important. So as we said, it's an interaction. I left out the hormones and metabolic because we're going to rule that out in our testing, but it can play a role if you have a chronic kind of condition where your blood count's going to be low or you have low blood pressure. But it's an interaction between all four of these things. So when patients come to me, they have trouble, they think it's their ear. Give me, fix my ear. But really it's one of these other problems that get in the way. And it's a relationship between all of them. So what do we do when we see a patient? First, we come in and we're going to ask a history. Now, because we can't see into the inner ear, the history is very important. It tells us what type of syndrome that you probably have. So So in other words, if you have positional vertigo, the classic is, I can't watch TV in bed because when I put my head back, I get dizzy in one position. So something positional, or I bend over and I get dizzy, and then we ask, well, how long does the dizziness last? And they say, well, it only lasts about 15 seconds, but it really spins, and then it goes away, all right? So that's pretty classic for positional vertigo. But if they come in, they say, I had this severe dizziness about a week ago, it just knocked me out, I was on my back for 2 days in the bed, and I couldn't move. And now, 2 weeks later, it usually takes 2 to 3 weeks to come to see me because you've got to get a referral through your primary care. And then they say, you know, it's largely gone away. I feel much better now. That first 2 days was terrible. I'm going to ask, well, what was your hearing like? What was your hearing like during that time? They said, well, the hearing was fine. Okay, so that tells me it's probably not a tumor related to the ear or something. And that's pretty classic for a viral illness of the inner ear that's going to clear up on its own and get better. So that tells us a lot just by history alone. The other thing is Meniere's disease. That's a term that's used commonly. It's unusual for elderly people to get Meniere's unless they've already had it before. So Meniere's, they get that acute dizziness and whirling vertigo where the room is spinning, but the episodes only last 1 to 4 hours. And then the rest of the day, they're kind of a little bit groggy, but by the next day, they're fine. So it's the episode is 1 to 4 hours. It's not 15 seconds. It's not 1 to 2 days. It's 1 to 4 hours. That's pretty much classic Meniere's. And with Meniere's, the hearing will also drop during that time, usually. So again, the history is very important. So when you have your dizzy spells, take some notes so that when you see the physician, you can talk it over with them. So the clinical dizziness evaluation. So after the history, we want to do some testing to see, is this an imbalance problem? Is this something central with the brain? And so we'll run them through a series of tests. The first is a clinical test for the central part of your brain. And we'll ask our beautiful model, Dr. Hinshaw, to come up here. All right. So the first thing we'll do is do a Romberg test. Now, the Romberg test is to sense if you're going to fall. It's usually indicative of a central problem. So we'll have you put your heels together, and just like that, with your toes facing out, and we'll have you raise your arms straight up, and keep your eyes open. Now, if you start to fall, I'll catch you.
That's good.
All right? So go ahead and close your eyes. Okay, good. You can open your eyes now. All right? So that's the Romberg test. So we know that everything's probably in pretty good shape. She's not falling over, certainly looking good, having a good day. So that's the first test. The next is the tandem Romberg. So we'll put her heel and feet together like this. Okay, so this one's harder. I was doing this at home, and I was falling a little. So, okay, all right. Okay, so that's before we have you close your eyes. All right, so some patients, they're not going to be able to take this position. So what does that tell us? It's not a brain thing. It's a proprioception thing. Their feet, their knees, their stability down here isn't quite helping them, right? So it's something we all have. So it's more of a proprioception thing. All right, she's in pretty good shape now. All right, close her eyes. All right, great. Thank you. So what happens is if you do have a central problem, you'll tend to fall to one side consistently. So that tells us, well, we better order a brain scan to make sure everything's okay up there. And but here's a case where everything's pretty good. She had trouble initiating the tandem Romberg, like many of us do, and that indicates more of a proprioception thing, problem with her joints, etc. Then we'll do the Dix-Hallpike, which is a little different. All we do is we have the patient, let's say I'm sitting up, now I'm going to lie down and put my head to one side. So with my head to one side, I ask the patient, are you dizzy? They say no. Then I sit them up again, then I lie them back down, put their head to the other side, if they get dizzy or not, yes or no. So that one is for the positional vertigo. And so those tests in the office help us determine what might be going on and additional tests we might get. The optometrist, ophthalmologist will say, when was the last time you had your glasses checked? I had one patient the other day said, you know, this dizziness and imbalance started after I got my cataract fixed. I'm waiting to get my other cataract fixed, and since then I've been dizzy, all right? So obviously there's something going on there where there's an imbalance between both eyes that needs to be corrected for that patient. So the other test, we're going to get a hearing test. We're ear doctors. It gives us a general sense that if the hearing is normal in both ears and symmetrical, then it's probably not a tumor of the ear causing it. And if you go to the doctor with an asymmetric hearing loss, we're going to order a brain scan because we want to make sure that there's not a tumor of the ear, which is, it's not rare, but it's not common either. And you're going to know it because one ear is not hearing as well as the other. And so we'll test that. Blood tests. So we'll cover this here and not mention it elsewhere. But here's something where it's the most common cause for just imbalance. And people forget about this. If you have a chronic anemia state or just developed anemia for some reason, low blood count, you're going to feel a little lightheaded. You're going to feel a little lightheaded. And if you go to altitude, even on an airplane, it's going to get worse. So blood count, now your primary care physician will rule that out with tests and tell you to take a multivitamin with iron. Other things like low thyroid. All right, so low thyroid, you're going to feel a sense of fatigue, may feel a little bit imbalance. So they'll check that out too when they do their blood tests. Low blood pressure, all right? So that's something, some people do have low blood pressure. As we get older, most blood pressure goes up. It's just a natural phenomenon as the arteries harden. So you might be getting too much blood pressure medication, which could be dropping your blood pressure. The other thing is when you're sitting and then standing up, some people have a drop in blood pressure. All of us do to a certain extent. So when you get up in the morning, get up, sit on the side of your bed for about 30 seconds to a minute. When you make that first step up, do that. Otherwise, you know, you might be lightheaded, you might tend to fall. So you have to go slower. By definition, you're going to have blood rushing away from your head that's going to make you dizzy. So you just got to take your time in the morning. Vestibular testing. So ear testing we don't always get, all right? So that positional vertigo thing, we're not going to get ear testing if your hearing's normal, all right? If you had this acute episode and it's cleared up and there's no lingering effects, we're not going to get it. We will get it in times where, hey, this thing should have cleared up, but it hasn't. It keeps going. Or you had a pretty severe incident here and you haven't recovered, or it's not fitting the pattern, then we'll go ahead and order some of that testing. And a brain scan, don't always get it, but we'll get it in cases, again, we haven't really solved the problem. We want to make sure nothing serious is going on. So let's talk about the specific tests. So the eye, we want you to go see your optometrist or ophthalmologist, get a good eye check, and get your prescription checked. So and do some visual field testing. The reason why this is important is, as Dr. Hinshaw will tell you, when you close your eyes, the room will tend to spin. So I want everyone here to just put their arms straight out with their palms up and just close your eyes right now. Okay, you can open them. So many of you probably felt, okay, it's, you know, I'm not moving it at all, but when I do that, it just takes me a second to reorient. It does feel a little unsteady to me. You lose your eyesight. It's a tremendous disadvantage to feeling steady. And that's one of the first rules if you've this is the cruise generation I see sitting in front of me. You know, how many have been on a cruise? Okay, not too many, but you know. So the thing is, on a boat, the first rule of thumb they tell you is focus on the horizon. So the worst thing to do is be on your cabin and the boat's doing this, and you can't focus on everything because everything's moving. But if you can get to the deck and you can see the horizon that's flat and not moving, you focus on that, and everything else around you moving doesn't matter. So that's one of the first ways to prevent seasickness. Same here. If you have cataracts, if you have problems with your eyes, your prescription, everything seems a little blurry, it's hard to stay balanced. Proprioception, generalized joint instability. So as we get older, knee replacements, hip replacements, loss of sensation, diabetes, big problem for the elderly. As we get older, diabetics, they lose some of the nerve endings in their periphery, in their feet, and so they can't sense the ground as well as they used to, all right? And so because of that, you'll tend to stumble, and it will give you that sense of imbalance. Now, if you haven't had your prescriptions changed recently and you're diabetic, and diabetics have generally poor vision because they have retinopathy, problems with their inner part of their eye. So now you have two things working against yourself. So again, that general test there, we kind of know that as we get older, we get a little shaky. That's kind of normal, all right? And so then it interacts with your eyes and other factors. The ear. All right, so this is about ears, but we said it's not all about ears, right? So we'll look for vestibular testing. If it doesn't fit the pattern, we'll send you to a testing center, or some of the doctors will do it in their office. We use the Balance Center of the Pacific. It's on Kapiolani Boulevard. Your primary care can refer you there. They'll run you through all kinds of vestibular testing. They'll even have, like, if you're generalized dizzy and the initial tests don't work well, they'll lie you down and then sit you up and see if you're dizzy, and they'll check the blood pressure, all these kind of things to see why you might be dizzy. So we've had good success in finding out for many patients what's going on. The other thing is one ear could be in slight imbalance. One ear could be more hyperactive or hypoactive, and it's not in balance with the other ear. And so that can lead to problems. Some people, they're just prone to motion sickness. There's probably one or two in the room here, they just can't go on a boat. Any kind of motion, they go on a plane, they ride in a car, they get car sick. Some people just have hyperactive inner ears. They're going to tend to get dizzier for a lot of different reasons because they're so sensitive. Now the brain, as we get older, there's aging changes versus specific findings. As we all get older, your little blood vessels, they get stenosed off, they get stenotic due to atherosclerosis, and same with the brain, all right? So the skin gets a little drier, more brittle. The brain, lose some of your memory here or there. The function's not the same. That's just a normal aging change, all right? So that's what we see, and again, you have to relate to the environment, and that's why that's important. Or we could find specific findings. So MRI scan for severe, acute, progressive, persistent, or progressive changes. So if your dizziness history doesn't fit, we'll go ahead and get the brain scan. If you go to the emergency room, you have that 1 or 2 day history of the severe vertigo, and you're really down and out, they're going to order a scan of some sort to make sure that nothing dangerous like a stroke has gone on. A stroke per se will not present with dizziness alone. You might have dizziness with some other symptoms like a focal deficit, some weakness in the arm or something like that. That's more characteristic of a stroke. Or loss of mentation, sleepier. Again, isolated dizziness, unusual or rare with a stroke alone. Usually you're going to have something else. We mentioned the tumor of the inner ear. It's usually a tumor of one of the nerves. And again, we get what happens there is patient says, you know, I don't hear so well out of this right ear anymore. And that's been going on for the last 3 to 6 months. All right, and the room feels a little bit unsteady. So, and actually one of the main symptoms for that, they'll say, we ask, what about, everything's okay during the day, you're not dizzy. What about when you turn the lights off and you're walking around your bedroom at night? Do you feel unsteady? They go, yes, I do. And that's another prevention tip, night lights, right? So if you take away the vision and you can't see and you're stumbling around at night, not good. So I'd recommend a night light in your room to make sure that when you get up, you can see, all right? So what is the treatment? Like everyone gets dizzy. I was talking to one friend in the back room, and he said, you don't have much on treatment. I go like, well, we'll get to some things. But the first thing I'll say is get to your eye doctor. Let's check your glasses, make sure your vision is intact and things are going well, all right? If you haven't seen your eye doctor in 2 or 3 years, that's probably playing a role. Exercises. So some of these will be specific physical therapy for the ears. So they'll put you through various motions and all that. And a lot of that is just conditioning your ears to tolerate movement, tolerate different positions, so that it makes you more able to compensate when your ear is off balance. And generalized exercise, like Tai Chi, I know you had a session here on that, and dancing. These generalized motion type things help your proprioception, help you sense the ground, help you stimulate the inner ear and your eyes to tolerate some degree of motion, and helps keep you in balance when you're static. Prevention. So use a walker or cane, even if not needed all the time. It can prevent falls. So the bottom line here is you don't want to get dizzy and have a fall. And if you're diabetic, your knees and joints, you've had a knee replacement, you're a little unsteady, to walk without a cane and to stumble and not have something there, you don't want to go through a fractured hip. There's even a mortality rate with a fractured hip. So it's something, prevention is probably the biggest thing for most dizzy problems. All right, let's talk about some specific vertigo problems. Benign positional vertigo. This is something that comes up all the time. We see it frequently. And it's actually, when we see it, it's great because we can actually fix it. Most of the time we can fix it. So again, you'll know it because we'll put you through that one maneuver. You'll put your head back to one side on the pillow at night and turn it to the right, and the patients will say, I can turn my head to the left. When I turn it to the right, man, the room spins, and then we duplicate that in the office. All right, so it lasts about 15 to 20 seconds, and then it goes away. It's due to otoliths, and we'll show some pictures of them. They're microscopic level little crystals that fall off of your hair cells in your balance area, and then they cause problems, all right? And then we'll do the Epley maneuver. So unlike some of the other exercises, the Epley maneuver is a maneuver. It's not something you're going to repeat. It's usually a one-time session, maybe two-time session. It kind of floats these crystals out of the bad part of the dizzy area into the good part. All right, and we'll show some pictures of that. So again, benign positional vertigo, we're going to put your head back on the pillow to one side and the room spins. All right, last 20 seconds, 15 to 20 seconds, then it goes away. It's due to these little crystals. It falls usually to one canal, the posterior canal. And the posterior canal's back here. We'll show pictures of that. And when you go back there, that head motion moves these crystals in relation to the water, causing the dizziness. All right, and then we'll do the Epley maneuver. Again, this isn't an exercise like some of the other things. This is actually a maneuver to float those crystals out of the canal. It's part of the balance system. They can fall off the hair cells that they sit on and cause problems. So let's take a picture of the inner ear. So here's your external ear, and then sound's going to come in. It's going to vibrate against your eardrum. The three smallest bones in your body are here, the malleus, the incus, and the stapes. And note the stapes looks like a stirrup, right? And then it vibrates into the inner ear. and it creates sound. So the inner ear is composed of two areas. One, this is your cochlea. That's the sound generation portion. And these are your semicircular canals, and that contributes to your balance. So each of these canals are in one direction or another. All right, so this is the superior, this is the lateral, and that's the posterior. So they're oriented in three dimensions such that they can detect movement in each dimension. Because of gravity, the otoliths will fall back into this posterior canal. The posterior canal is situated backwards, so because of gravity, they'll tend to collect there. These are the nerves. There's actually 4 nerves. There's the vestibular nerve, there's an upper nerve, and then there's a lower, and then you have the nerve for hearing, which is a separate nerve. The 4th nerve that comes out in this area is the nerve that moves the side of your face, the facial nerve. Okay, so let's look closer at the vestibular area. This is the area for dizziness. Here's your posterior canal. Here's your anterior or superior canal, and then your lateral canal. So what happens is these, they're called otoconia, or little crystals. They sit on these hair cells, and these are microscopic, all right? You're not going to see them with your eye. They're microscopic under the microscope. They're in this area here, and they fall off. All right, they fall off, and they gravitate by gravity back to your posterior canal, and they live right in this area. All right, so how do they fall off? They can just fall off de novo. No one knows why. You may have had a car accident where you whiplash or something, just a sudden jolt that can jar them off. All right, and then after, what happens too, there's a phenomenon. When they fall off, you get dizzy. And it's an unusual kind of dizziness. And then similar to like an inner ear kind of like virus, they have the same kind of symptoms. And then it localizes to this positional thing. So when it falls off, you get dizzy. And then when it localizes, then you get that persistent vertigo, which is the positional type. So the emphasis of these maneuvers is to float those crystals back out of this area, float them back out into this larger area where they don't cause a problem. Can they float back in? Sure, they can. Then you do the procedure again, and then they get better. You can find the procedure online. So look online, they have it. If you have problems doing it and you specifically know you have the problem, then come in and we'll do it with you. It's best to bring a driver when you come to the doctor's office if you have this. Because if you don't have a driver, we're not going to put you through the maneuvers. Because there's been reported cases of people, they drive home, they get dizzy on the way home, and then they get in a car accident, so we don't want that to happen. So bring a driver, do it later in the day so you can go home, just take it easy after. It's really, most patients walk out, they do fine. But you can feel a little unsteady after the maneuvers because we are going to make you dizzy. We know it works because by the end of the 5th episode, the dizziness in that initial position is gone. So that's when we know it works. Now sometimes, like every place, these things can get sticky. They can stick back there. They can stick to the membrane. All right, so then the originator of this, Dr. Epley, he'll put a vibrator on the patient that'll buzz, and then he'll put them through maneuvers. But usually I haven't had to do that, but some patients require something like that. So very ingenious. He was a Stanford graduate in ear, nose, and throat. And what he did is he made a physical model of this. And then he put crystals in there, and he put the model through the different rotations, and he saw how the crystals floated out of there. And then he applied it to clinical practice. I've met him personally. He's a great individual and really helped solve this problem, which has been around for many years. So again, not an exercise. It floats these things out of the canal. We perform it 4 to 5 times in a row. So we'll put you in one position. The first position, if you're right ear, we'll have you lie down with the right side. You get dizzy, Okay, dizziness goes away, we wait 15 seconds. Then we go to the left side. All right? Then the first two positions are really easy to remember. The side that bothers you, and then the opposite side. And then the third and fourth positions are fairly easy to remember too. It's chin to shoulder. The third position, you're going to lie in the bed, and you're going to be face down on the bed, on your side. Face down on the bed. And then the fourth position, you're going to get up with your head towards your shoulder. Fifth position, back to neutral. All right, so you can find that online. And you'll know it's working because by the fourth or fifth time you put your head back here, the dizziness is largely gone or completely gone. I tell patients, do it at home. If you don't bring a driver, I run you through one episode. I give you a handout. Go home, do it. By the fifth time, the dizziness should have gone away. If it doesn't work, you'll know it works because next time you put your head down to the right, you'll be dizzy. Then you got to do it again. But you only do it about a week later. It's not an exercise you do every day. You should only do it once or twice. Okay, so this is the viral infection of the inner ear. All right, so here the room spins, and the main episode can last 1 to 2 days. It knocks you out. You're flat on your back, any kind of motion, and then, it improves. Every week it gets a little better. And many of you have probably had this in this room, all right? Some severe kind of thing. The first thing I'll ask is your hearing. How was it during the episode? So, well, hearing's fine, so I kind of know that it's not a tumor, all right? And they say, it's, I tried to get in to see you, but you can't get in to see you, right? It takes 3 weeks, right, to see me. So by the third week, they said, I feel better now. It's like I didn't need to come in, right? So that's the kind of thing. Or they'll say, it's 3 weeks, I feel much better than I did, but I'm still not quite back to normal. And the older you are and the other things you have going on with your eyes and all that, it may take you longer to compensate. So the thing there is, I say, day by day, you're not going to notice a difference. But is this week better than last week? They go, oh, yes, this week's much better than last week. Then I say, okay, let's continue on that. By 6 weeks, if you still have imbalance, you need to come back because then we need to get a brain scan, make sure nothing's wrong. All right? So that's how the process with this is. Treatment, you'll get at the emergency department or a PCP, they'll give you meclizine. That's a commonly used one. Scopolamine patches, what we use for seasickness, right? They'll put it behind your ear, and it gets absorbed through your skin over a 3-day period. And it helps that sense of imbalance. Both of these, meclizine can cause drowsiness. The other one will cause maybe some blurred vision, which doesn't help your dizziness, and some dry mouth. Meniere's disease. Again, we talked about this. This is due to fluid buildup in the inner ear. There may be 1 or 2 people sitting here that have had this diagnosis. You're not going to get it diagnosed in the elderly. You probably had it since you were 30 or 40. And these episodes last 1 to 4 hours, then they dissipate. You might have 2 to 12 episodes per year. All right, so how do we treat that one? Because it's due to fluid buildup in the inner ear, we treat it with salt restriction, low salt diet, and diuretics. We want to reduce that fluid buildup in that inner ear. If that doesn't work, there are some surgical procedures where an ear surgeon might operate on that, depending on the severity. Again, this is unusual for elderly to experience this if they haven't already been diagnosed with it. Okay, so we covered a lot today. In summary, most dizziness of the elderly is multifactorial. All right, involves the age-related declines in the ears, the eyes, proprioception, and your brain. Evaluation will find specific causes to treat, such as positional vertigo. General treatment is motion exercises for generalized dizziness with some specific physical therapy exercises for the ear. Sometimes you'll be sent to a physical therapist. They'll do generalized exercises to move you around, make you dizzy, all that kind of stuff. That's just to habituate you a little bit, so that you can tolerate motion. Here, the key is if they can't do anything, prevention of falls is critical. You need to bury your ego. Don't be hard-headed, all right? So the thing is, as we get older, men and women, stay off ladders. Really? I mean, you hear this, it's like when visitors come and they go body surfing at Sandy Beach. Are you kidding me? Did anyone tell you that that's where people break their necks? All right? So going up on a ladder when you're probably, a certain age is probably not wise. If you're going on a ladder, you should probably only go up to the first step or second step and have something to hang on to in a very stable ladder. Otherwise, you're just asking for trouble, right? So use a walker or cane. Now this one, people have trouble wanting to do that. It's kind of like, they show this picture of, and I tried to find it, I couldn't, but it's the life cycle of a human being. And I've had elderly, my mother passed away, my father-in-law and mother-in-law just passed away, but it's a picture showing that you're born in diapers and you die in diapers, right? So it's the life cycle showing that. And when you're a 1 or 2 year old, you can't tell anyone anything, right? You can't tell a 2-year-old what to do, right? You can't tell an 85-year-old what to do either, right? So it's kind of like the life cycle kind of repeats itself. I mean, so don't be hard-headed. If you find yourself, as you get older, being more hard-headed, you need to kind of like write that down and say, don't be hard-headed, because that's going to prevent you from using that cane or walker, right? And then they'll fall, they'll break their hip, end up in the hospital, in rehab for a couple months. It's just miserable. You don't want to have that happen. So don't be hard-headed. Don't be a 2-year-old, all right? Act your age, all right? So I think that's all important. Assistance devices in showers and baths. This is something that's critical, all right? Add those. They cost some money, but my uncle, he was still in pretty good shape, had no significant problems. He slipped and fell in the shower, hit his head, had an intracerebral bleed, died. So we've all heard stories like that. So don't let that happen to you and your loved ones, all right? So put those things in there, because when you slip, you can grab something, all right? Okay, so any questions?